Good afternoon, everyone. We'll be discussing this topic about antibiograms, how to read and interpret an antibiogram. So what is an antibiogram? It is basically a lab report which shows you the susceptibility results of a particular isolate to a given battery of antibiotics. Okay, so that is the basic definition of an antibiogram. So we have two types of antibiograms. One is the hospital antibiogram, which periodically summarizes the results of susceptibility patterns of all the pathogens which were isolated from during that period, from that facility or that ward. And this is used to guide empirical therapy. It gives the susceptibilities in percentage rates, and it also detects and monitors the antimicrobial resistance trend. So this is hospital antibiogram. Now you can have routine antibiogram and enhanced antibiogram. Routine antibiogram, by routine antibiogram, I mean that we just take out all the isolates and all the susceptibility patterns of all these isolates from a particular facility. But if we specify the syndrome associated with these pathogens, for example, if we make an antibiogram for specifically for urinary tract isolates, then it will be an enhanced antibiogram. All right, so routine antibiogram and an enhanced antibiogram. Other one is patient-specific antibiogram. So this is the patient's report you see every day, the AST report, and it is used to now move from empirical to targeted therapy. So in the picture, you can see there is a big chart, color-coded chart. This is an antibiogram. Specifies that it is for the urinary tract isolates only. In the pink and blue on the extreme left column, you can see the pathogens which have been isolated from urinary tract infections and the various susceptibility rates to various antibiotics. The susceptibility rates are mentioned in percentages and they are color coded as well. The reds show the susceptibility are it is less than 70% to that given antibiotic. In the greens are the ones for which the susceptibility rates are more than 90%. And the yellow coded susceptibility rates are those for those isolates, like for those antibiotics which were 70 to less than 75% of the isolates were susceptible to that antibiotic. And in some columns, they have mentioned R and S. R means intrinsically resistant. So even if we report it as we see the in vitro susceptibility, we report them as resistant. Okay, they have mentioned the in the corner on the left side below. They have mentioned the period also for which the antibiogram was prepared, that is from April to June. And they have color coded the gram-negative and gram-positive organisms also. So this is basically a very good antibiogram, which summarizes the pathogens, give the general susceptibility patterns also, and the syndrome associated also. And it is from a specific location over a specified period of time. So now this picture shows the patient-specific antibiogram, which is for a particular patient for a particular isolate. And the single isolate, the susceptibility rates for that single isolate has been specified in this. So we can switch on from empirical therapy to the targeted therapy based on this specific antibiogram for that patient. So how do we interpret these susceptible or resistant categories? What we do, we read MICs, that is the minimum inhibitory concentrations for an antibiotic for a particular isolate, or the zone diameters. In the picture, the middle picture, you can see there is a micro titer plate. The plate is having 96 wells. What we do, along the x-axis, we dilute the antibiotic serially. So the antibiotic concentration decreases from along the x-axis. While we, after adding the antibiotics and different concentration, we add the bacterial inoculum as well. And then we incubate it overnight and we look visually for the growth. You can see in the wells in the first row that the wells 1, 2, 3, 4, 5, and 6. These wells are showing growth buttons at the bottom of the well. In the next well, there is slight decrease in growth. In the next well, there is no growth. So whatever lowest concentration of antibiotic is there, which is inhibiting the growth, visible growth, is given considered as MIC, that is minimum inhibitory concentration. Again, like for example, if we start with the antibiotic levels of 256 microgram per ml, suppose this well is having 256 microgram per ml of MIC of the antibiotic concentration, then after diluting it, this will be 128, then 64, then 32, then 16, then 8, then 4, then 2, then 1, 0.5, 0.25, 0.125. So here the MIC will be 0.125, 0.25, 0.5, 1, and 2. This MIC will be 2. Okay, so this will be the lowest concentration of antibiotic which inhibits growth. Then we have we put this diffusion test also. What we do is we have a culture media plate over which the test organism for which we are testing the susceptibility is put in the form of a lawn. The lawn culture is put up, and then we apply the various antibiotic discs over it. After overnight incubation, we look for the zones of inhibition. Around this antibiotic, suppose there is a big zone of inhibition. In this zone, there is no bacterial growth. So what we do is we just measure the diameter of this zone, and we compare these MICs and zone diameters with the breakpoints. What are the breakpoints? Reading of 30 or 20 is meaningless, right? We have to compare it with something. So what we do, we have authorities, CLSI, like CLSI, in our lab, we follow this CLSI standards. These are clinically and laboratory standards institute, which annually updates the breakpoints. This is M100 document. What they do is they release the breakpoint interpretive category definitions every year for every organism, bug drug combination. It's like a bug drug combination. For example, in Staphylococcus aureus, they will have breakpoints for vancomycin, for linezolid, and other drugs also. For every organism, every pathogen, they are having this in this document. For example, you can see that interpretive category susceptible, dose dependent, intermediate, resistant, and non-susceptible are given. And in each category, certain breakpoints are given, which are the minimal inhibitory concentrations or the zone diameters, which are used to categorize the particular organism as into these interpretive categories. All right. For example, if we have to consider an organism as susceptible according to this chart, if the MIC is less than equal to 4, then only it will be considered as susceptible. If the MIC is more than equal to 32, then it will be resistant. Similarly, the breakpoints are given for zone diameters also. MIC and zone diameters correlate with each other. All right. So for each organism, they have given zone diameters also to categorize it as susceptible or resistant. And for the same organism, they have given MIC breakpoints also. All right. But there are certain special circumstances for which disc diffusion, the application of disc, the methodology I told you earlier, is not recommended. Why? Because certain antibiotics cannot penetrate through the culture media which we use for antibiotic testing. So for those antibiotics, they have recommended that we do MIC testing only. So what are these drugs where only MIC is recommended? Colistin testing. Right now, we are not having colistin strips and we are not performing microdilution. So we are applying this only, but they are not recommended methods. Colistin MIC is to be determined. Zone diameters are not the recommended method for colistin susceptibility. Then vancomycin and daptomycin for Staphylococcus aureus, and levofloxacin for Burkholderia capacius. So you must demand MIC for these bug drug combinations. So now you know what an antibiogram is. So starting with the utility of an antibiogram, first use is to decide upon the empirical treatment. You know, empirical treatment is given to a patient with signs and symptoms of syndrome prior to the availability of culture results. We don't have culture reports available. So it is the best guess which we can give to a patient based on the site of infection or the patient risk stratification. For example, if the patient has had a history of previous exposure to antibiotics, or the patient is severely ill, or the patient is still admitted to the hospital, then the risk is greater. Okay, so based on these parameters, we decide upon the empirical therapy. And it may not be the broadest spectrum of antimicrobial agent covered, always. So WHO has given recommendations for antibiogram-based empirical treatment. It says that in patients in whom the risk is high, risk of mortality is high, for example, in patients with sepsis or meningitis, or patients in the ICU, we should choose an agent which has susceptibility of more than 90%. All right, from the antibiogram, because the antibiogram gives us the susceptibility rates. Now we have to choose the empirical agent for that particular bug drug combination, for that particular bug. So we look at the susceptibility rates for the agents which have a susceptibility rates of more than 90%. Only they can be chosen as empirical therapy if the patients are at greater risk of mortality. Then if the patient is without any significant risk of mortality during the next 1 or 2 days, for example, community acquired infections, then a lower threshold, even up to 80%, may be appropriate. Then if there are no such agent available which has sensitivity of more than 80%, then we choose the agent with the highest susceptibility rates, and it should be considered for the patient based on the site of infection and the infecting organism also. So these are the recommendations for empirical treatment. Second use of antibiograms is monitoring trends of antimicrobial resistance. We know that incidence of antimicrobial resistance is increasing, and we have so many new resistance mechanisms, and the older ones, especially the beta-lactamases and AMC and carbaphinamases, these are increasing. And third thing is MIC creep. MIC creep is what we do. We look at the gradual rise of MIC. For example, in this chart, you can see the 4 graphs are there, A, B, C, and D. Just look at the graph A and C. The graph A is for vancomycin in case of Staphylococcus aureus, and the graph C is for teicoplanin. By MIC creep, I mean that the MIC should rise gradually during the few years. So if we just look at the darker bars, dark blue, dark green, and dark orange bars, this is for methicillin-resistant Staphylococcus aureus. In methicillin-resistant Staphylococcus aureus, vancomycin is the mainstay of treatment for in many situations, and it is seen that the increase in MICs of vancomycin is associated with poor clinical outcome, clinical failure. All right. So if we see in 2012, the blue bar, the dark blue bar, is showing the MRSA isolates with the susceptibility rates in sensitive range. Okay, they are not in intermediate range or resistant range. You can see these blue bars are 25%. While in 2016, these MRSA isolates with a very good, very low MIC have rose to 57%. That means MIC creep is not there. All right, the sensitivity is rather increasing over time. We are getting good isolates with a much lesser resistance during these years. Now, if we look at the teicoplanin, starting in 2013, we have a good number of dark blue isolates. These are 94 in number, which means an MRSA, these are MRSA isolates with an MIC of 0.5 microgram per ml, which are like in susceptible range only. But if we look over the time in the year 2015 and after that, these blue ones have decreased and the greens and orange ones have increased. The greens and orange ones are the isolates with increasing MIC. All right, so from blue, it is shifting to more green and more red. That means there is MIC creep over these years. MIC slowly increasing, gradually increasing. So this is also one thing which we can interpret from antibiogram by looking at the MICs during the years. Third use of antibiogram is MIC guided therapy. We know that MIC helps to select most appropriate antibiotic. So if a pathogen is susceptible to more than one antibiotic, how do you correlate with the efficacy, clinical efficacy of that antibiotic? What we do is we take the ratio of the susceptibility breakpoint. By susceptibility breakpoint, I mean the CLSI breakpoints. The CLSI categorizes, suppose if a zone diameter of 20 mm, if an MIC of 8 microgram per ml has been given as susceptible, that means below 8 and equal to 8 will be susceptible. The isolates with MIC of less than or equal to 8 will be susceptible. While if MIC is more than 8, if it is 16, 32, that will be resistant. So if we divide that susceptibility breakpoint given by CLSI by the MIC which we have obtained through our test, then that gives us breakpoint MIC quotient, which is BMQ. Earlier, it was known as therapeutic index, which is a misnomer. Therapeutic index should not be used. This term should not be used. Instead, BMQ should be used. This is breakpoint MIC quotient. And higher the BMQ, the more efficacious is the drug. This can be explained by this example. Suppose I tell you that there are 5 antibiotics. Antibiotic A is the MIC of the pathogen to antibiotic A is 64. To the drug B is 4. C for the C, the MIC is 1. For D, MIC is 0.125, and for drug E, it is 4. So if we look at the MICs, we can jump to the conclusion that the agent with the lowest MIC will be the most effective. So in case, maybe you'll think that D will be the most effective agent by just looking at the MICs. But this is not true, because now we have to see the distance between the MIC and the susceptible breakpoint, that is the BMQ, breakpoint MIC coefficient. This is the picture of E strip. which has a continuous gradient of antibiotic. This is a strip loaded with antibiotic in varying concentrations. Okay, you can see it. The highest concentration is 256, followed by 128, 96, and so on. So if you see the drug A, this is the edge of zone which was obtained for MIC. Suppose this is the zone which was obtained, and this level is way beyond the susceptible breakpoint. Susceptible breakpoint is here. So this drug is almost, this pathogen is almost resistant to this drug. Coming on to the drug B, the MIC lies in the intermediate range. That means the bacteria is somewhere between susceptible and resistant. Maybe higher doses of drugs or higher frequency may help in this case, but still it is an intermediate category. Now coming on to the drugs C, D, and E. For all these three drugs, the MICs are lying in the susceptible range, right? It is below the susceptible MIC breakpoint. The MIC breakpoint here in case of drug C is 16, and we are getting an MIC of 1. For the drug D, the MIC breakpoint is 0.25, and we are getting the sensitive, the MIC at a bit lesser than that. For drug E, we have susceptible breakpoint at 16, and we are getting around 4. The MIC is around 4. So can you tell the most efficacious drug? You have to see the gap between the breakpoint and the MIC which we have recorded. So in case of drug C, it is very far from the susceptible breakpoint. That means if the susceptible breakpoint was 16, the MIC below which isolate will be considered as susceptible is 16, and we are getting 1. That means between 16 and 1 there is a bigger gap as compared to the others. All right, so the most efficacious drug will be C, followed by E, because it has a bit lesser gap, followed by D. Others were resistant only. These three were only sensitive. So only MIC cannot guide the therapy. We have to look at the BMQ, that is breakpoint MIC coefficient. So along with MIC, you should know the breakpoints also. They should be mentioned in report. But they are all, there are so many factors, PKPD factors also, which guide the treatment. So it is not always possible to decide on the basis of one factor only. Similarly, regarding MIC, we know that MICs in CLSI standards, they have been based on serum breakpoints. That means they are based on the levels which are achievable in serum and which would likely result in clinical success. Okay, so interpretive criteria given in CLSI are based on the serum breakpoints for in vitro testing. Ideally, different breakpoints must be there for different sites of infection for the same bug and drug combination. For example, a 25-year-old female with UTI was started on amoxicillin empirically. The culture showed growth of E. coli with sensitivity to nitrofurantoin and ciprofloxacin and resistance to amoxicillin and cotrimoxazole. But the patient responds to amoxicillin despite of in vitro resistance. The patient is responding to amoxicillin. So what could be the reason? What? Yes. So any antibiotic achieves different levels at various sites of infection. For example, in this picture, you can see that the serum breakpoint is here, and the CSF breakpoint is here, shown by dotted lines, and the urine breakpoint is here. So if we have three isolates, isolate 1, 2, and 3, we can see that isolate 1 has MIC of 4, which is beyond the MIC required for CSF infections. So it is CSF breakpoint is 2, but MIC is 4. So most likely this isolate will be resistant to this drug if we are considering it for therapy of meningitis. Then for isolate number 1 only, if we see the serum breakpoint is 8 and the MIC is 4. That means the inhibitory concentration is still lower than the serum breakpoint. That means this isolate will be sensitive to this drug for bloodstream infections. Then next is urine. Urine breakpoint is somewhat near 128, and this isolate is again having MIC of 4, which is very, very less than the urinary breakpoint. So again, this isolate will be sensitive to this drug if given for urinary tract infection. Coming on to the next isolate, isolate number 2, we can see that the MIC is 32. So this will be the isolate will be resistant to the antibiotic in CSF and serum, but will be sensitive in urine. Then isolate number 3, it is the MIC goes beyond 128, goes till 128. So this will be resistant in all the 3 sites of infection. So how do we make sense of sensitivity? How do we utilize an antibiogram? Can we extrapolate our results from bedside to bedside? It is always not, it is not the case always, because 90% of the sensitive strains will respond, but 60% of the resistant strains will also respond. Why this happens? Okay, you will think of some lab error. Yes, that can also happen, but there are so many PKPD parameters also, right? Then we can decipher intrinsic resistance from antibiograms, which are mentioned in the antibiograms, and we can decipher other common resistance mechanisms also. Then we can use indicated drugs, and we can extrapolate our results from those indicated drugs to the other group of drugs also. We'll be coming to all these. Intrinsic resistance, we have already discussed this in previous lecture. So I'll be covering common resistance mechanisms. So this is a slide showing the beta-lactamase families. We have beta-lactamases which are posing a great concern since the last so many years. Then we have restricted spectrum beta-lactamases, which are penicillinases and cephalosporinases. Then we have extended spectrum beta-lactamases. Extended spectrum beta-lactamases work on 3rd and 4th generation cephalosporins also, and they are resistant to monobactams also. So if you are getting an AST report, which is showing you the resistance to ceftriaxone, ceftazidime, cefotaxime, plus aztreonam, but it is sensitive to carbapenems, then you can think of an ASBL. All right. So other one is AMP-C. Then we have carbapenemases. The most common carbapenemase in India is NDM, New Delhi metallo-beta-lactamase. So for all these carbapenemases, the carbapenems, the agents, the pathogens will be resistant to the carbapenems. For MBL specifically, the metallo-beta-lactamases, the resistance is not shown for monobactams, aztreonam, right? So for NDM, if it is resistant to all the drugs except monobactams, what can be the possible treatment choices? Anyone? Treatment choices for MBLs? Polymyxins, yes. Colistin. Not monotherapy, dual therapy or triple therapy may be given. Even carbapenems in combination with aminoglycosides or colistin may be given. Then there is a new drug, ceftazidime avibactam. And suppose an MBL is there, which will respond to avibactam. It will not be able to combat avibactam. We give ceftazidime avibactam for these kind of infections. But suppose if an organism is harboring MBL as well as ESBL, so now it will be resistant to ceftazidime also, right? Which is a very common scenario because the organism may harbor multiple resistance phenotypes at the same time. So we cannot decipher everything from a patient's report. All right. So in that case, what is the agent of choice? A new agent has come up. There's a new drug called ceftolozane, right? Ceftolozane tazobactam. This combination can be given. So dual therapies and triple therapies work in such cases. So coming on to the case scenario, patient with enteric fever was started on ceftriaxone empirically. The blood cultures subsequently grew Salmonella typhi, which was resistant to quinolones and ceftriaxone. Antibiotics were changed to intravenous meropenem. But the patient continued to be febrile even after 4 days of treatment with meropenem. And the cultures were still growing Salmonella typhi. And the fever effervesced when oral azithromycin was added to the regimen on the 5th day. The AST, as given by the lab, the resistance was to amoxicillin, ciprofloxacin, and ceftriaxone, and cotrimoxazole. But the isolate was sensitive to meropenem and azithromycin. So what is the possible resistance mechanism? Basic penicillins are also gone. Then ceftriaxone also gone. Carbapenems are there, sensitive to carbapenems. That means it is most likely an ESBL phenotype. Okay. Next, an 80-year-old patient with bloodstream infection due to Escherichia coli. The isolate was resistant to cefazolin, cefoxitin, cefotaxime, ceftazidime. 3rd generation cephalosporins tak to gaya. And then ampicillin, amoxicillin, clavulanic acid, and cotrimoxazole. While it was sensitive to Astronam, that means monobactam activity is still there. Then cefepime, imipenem, meropenem, carbapenemases are working, and piperacillin tazobactam. What is the likely mechanism? Have you heard of AMSI? AMSI beta lactamases? Yes, this is the likely mechanism, AMSI beta lactamases. Because AMSI beta lactamases respond to cefepime, although they are resistant to many cephalosporins, but cefepime works for AMSI beta lactamases. And carbapenems are also are the agents of choice for treatment of AMSI beta lactamase pathogens. So this is most likely an AMSI. But again, as I said, there are generally multiple resistance mechanisms in a given isolate. So it is not that easy to confer all the mechanisms to an antibiogram. Right? And as a microbiologist, I have I've spent my last 6-8 years to learn all these mechanisms. So in this short lecture, I cannot tell you everything about it. It is a very hardy topic. So I have tried to incorporate all the basic things which as a clinician you can know and you must know. So if you get a staphylococcus which is resistant to cefoxitin, then what will be the interpretation? Methicillin resistant Staphylococcus aureus will report it as methicillin resistant, either Staphylococcus aureus or MR cons, methicillin resistant cons. And how to extrapolate this result? If an isolate of Staphylococcus is resistant to cefoxitin, that means it will be resistant to all the beta lactams except the 5th generation cephalosporins. Can you name 5th generation cephalosporins? Ceftaroline and? Yes. Then if a Staphylococcus species has been reported to be resistant to erythromycin and clindamycin, what does it suggest? It suggests that it has constitutive MLSB type of resistance mechanism, which means resistance to macrolide, lincosamides, and streptogramin B. And most likely quinoprestin and dalfapistin are likely to be bacteriostatic and cidal. Their doses may also have to be altered in such cases. For Enterococcus species, if the Enterococcus is susceptible or resistant to ampicillin, we can extrapolate these results to other penicillins also, like amoxicillin clavonate, ampicillin sulbactam, and piperacillin tazobactam. For Enterobacteriaceae, if the resistance is shown to cefotaxime, but not to ceftazidime, see both are 3rd generation cephalosporins, and resistance to cefotaxime is there, but sensitive to ceftazidime. The isolate is sensitive to ceftazidime. It is a kind of ESBL only, but it is CTXM type of ESBL. Okay. So for ESBLs, the CLSI has set such breakpoints that we don't need to extrapolate these results. Okay, they have set such breakpoints that whatever drug is sensitive, we report it as sensitive based on the clinical breakpoint, and whatever is coming out to be resistant, we just report it as resistance. Because ESBL testing is not recommended by CLSI anymore. It is recommended only for epidemiological surveillance purposes only, not for the patient this thing. So next, if Salmonella typhi, you must have seen it is somewhere in some reports, it is written that p-floxacin sensitive or resistant. What is a p-floxacin? As the name suggests, it is a fluoroquinolone. And if the Salmonella typhi isolate is resistant to p-floxacin, that means it will be resistant to ciprofloxacin. And we have to be cautious against the use of other fluoroquinolones as well, okay, because it might not be clinically successful. So this was all about it. Any queries? I know I went fast because I had very less time. See, this is a plate where this is a disc of erythromycin, right? And this is a disc of clindamycin. I'm saying in case of Staphylococcus aureus or Staphylococcus species. So as you can see that clindamycin, around the clindamycin, there was a zone of inhibition, which has now been suppressed due to erythromycin. You see on the side of erythromycin, the zone has been decreased. So there is a D zone rather than a circular zone. There is a D zone. So that means erythromycin is inducing resistance to clindamycin. And in such cases, we report both drugs as resistant. And I told you it means constitutive resistance to macrolides, lincosamides, streptogramin B. So this might result in the treatment with clindamycin might result in clinical failure. So we have to be cautious against that. Another thing, inducible resistance is we test for AMSI beta lactamases also in certain pairs of gram-negative organisms like Pseudomonas. What we do is we put up imipenem disc. So imipenem is a very good inducer of AMC beta lactamases. That means the AMC which were repressed, which were not expressive in that pathogen. Now, what does imipenem do? Imipenem de-represses it, and the AMC is induced. So imipenem also forms the D zones with other beta lactams. So if the inducible resistance is there, that means if the therapy is started to beta lactams, it might the clinical response might be decreased, or even it may lead to clinical failure also within the next 2-3 days of therapy. So we have to be cautious in that scenario.